Okay, so we'll be starting off with endocrinology for step 3 from Master the Boards, and we will try to cover as much as possible in this one session. So, starting off with diabetes, the strongest indication for screening for diabetes is hypertension. A diagnosis is made with one of the following: either the patient will present with two fasting glucose greater than 126 milligram per deciliter, one random glucose greater than 200 with symptoms, and symptoms such as polyuria, polydipsia, polyphagia. Remember that this is an RBS of greater than 200. And abnormal glucose tolerance test, 2-hour glucose tolerance test with 75 gram glucose load. So if this is abnormal, then we will diagnose it. Or an hemoglobin A1C level of greater than 6.5%. Remember that you only require one reading of HbA1c, one reading of abnormal OGTT, and one random blood glucose greater than 200 with symptoms, and two fasting blood glucose greater than 126. And either one of them is going to give you the diagnosis. So only one of them is needed to make the diagnosis. HbA1c greater than 6.5 will be a diagnosis of diabetes. So diabetes is of two forms, type 1 and type 2. And we are comparing it in this table that the onset of diabetes in type 1 is juvenile, in type 2 it's adult. Body type, it is thin in type 1. In type 2, you find mainly obese patients. Diabetic ketoacidosis is a frequent occurrence in type 1. It is a rare occurrence in type 2. Treatment, you give primarily insulin in type 1, and most treatment involves lifestyle management or agents in type 2. And sometimes, if it is not working, if this management is not working, initial management, or the diabetes is refractory to any of your prescribed medication, then you go for insulin in those patients as well. Basic science correlate mechanism of type 2 diabetes. A short, brief mechanism is explained here. Adipose tissue must have insulin to permit entry of glucose and free fatty acids. Excess fat creates a deficiency of insulin. Insulin receptors are a tyrosine kinase, which is neither a peptide nor a steroid hormone receptor. Tyrosine kinase is also a mechanism for many forms of protein production. That's basically what they're saying, is that when you have excess fat in the body, it causes a deficiency of insulin. And if there's deficiency of insulin, what happens is that more fat gets deposited in the periphery and leads to various other kinds of problems. Because insulin is important for the entry of glucose and fats, right? So if you don't have insulin, you're going to the fat is going to deposit at the periphery, and there's going to be constant hyperglycemia in the blood because the glucose will not have any other place to enter. And insulin receptors are tyrosine kinase receptors. Okay, so you do require tyrosine kinase receptor to be present there in order for insulin to work. So type 2 diabetes treatment is as follows. First, you do the lifestyle change, then you go for the medical therapy. Diet, exercise, and weight loss is the best initial therapy. 25% of cases can be controlled with exercise and weight loss alone. Metformin is the best initial medical therapy. So the best initial therapy is this. And if you're going for medication, then metformin is the best initial medication therapy. It is particularly beneficial in obese patients because it blocks gluconeogenesis and it has no risk of hypoglycemia. This is very important. You must keep in mind that there will be several medications which will have a risk of hypoglycemia. Metformin is not one of them. It does not cause weight gain. Um, Sulfonylurea medications can cause weight gain, and they can also cause hypoglycemia. So weight gain and hypoglycemia are two side effects which are common in oral hypoglycemics and oral hypoglycemic medications. So you need to keep these two in mind. And when we'll be studying the medications, you must remember that these two are the ones that give commonly cause problems to the patient. Dipeptidyl peptidase 4 inhibitors, which have gliptin in their names, so sitagliptin, linagliptin, are used as second agent to metformin. They block metabolism of incretins such as GLP, glucagon-like peptide. So, uh, peptidase is basically what peptidase is. This is an enzyme, right? So, what it does is that it metabolizes GLP-1, GLP. So, if I could just, so the peptidase, what they do is that they metabolize the GLP agonists, right? So, if you inhibit this, then GLP will increase. If you inhibit this enzyme, the GLP will increase, and GLP is better for the digestion of glucose. So that's the mechanism of action of DPP-4 inhibitors. And similarly, you can just directly give GLP agonists as well, which is another form of medication, but we'll get to that in a bit. So the other class is sodium glucose cotransporter 2 inhibitors, canagliflozin, dapagliflozin, and magliflozin. Low mortality in systolic dysfunction, CHF, and delay progression of renal insufficiency. So there are two indications for this. Um, there are two indications for this. So that is CHF and renal insufficiency. Okay. SGLT2 inhibitors. And according to the current guidelines, SGLT2 inhibitors are given to the current patients who have indication of CHF or renal insufficiency. Side effects include UTIs. So this is important. And one more thing I would just like to clarify is that most of the things have been updated in medicine. It's an ongoing progressive field. Every day we get new updates regarding different guidelines. So this book is not necessarily up to date with guidelines. This just makes familiarizes you with the core medicine concept. It's not really something that you should completely rely on, and we should understand. Should look at the guidelines and then update yourself according to them as much as you can. All right, so thiazolidinones are again another class. Rosiglitazones, they have glitazone in their spelling, 5-glitazone. They increase peripheral insulin sensitivity. They may worsen congestive heart failure, so they do not use with CHF. So you are not supposed to use them with CHF. So whereas SGLT2 transporters you can use with CHF. Alpha glucosidase inhibitors, acarbose, miglitol, block the absorption of glucose at the intestinal lining. Side effects include diarrhea, abdominal pain, bloating, and flatulence, similar to lactose intolerance. So just remember the name acarbose and miglitol. Insulin secretagogues, netaglinide and ripaglinide work similarly to sulfonylureas. However, they are short-acting and they can cause hypoglycemia, same as sulfonylureas, which include glyburide, glimepiride, and glipizide. They can work by causing the increased release of insulin from the pancreas. They can lead to hypoglycemia and SIDH. So you can see that hypoglycemia is another side effect, and they also have weight gain, right? So this is weight gain, right? Remember that as well. A 65-year-old Hispanic man is seen in the office for follow-up. He was placed on metformin for type 2 diabetes several months ago after not responding to diet modifications and exercise. Despite maximal doses of metformin, his blood glucose today is greater than 150 and HbA1c is greater than 7%. What is the best initial management? So unfortunately, I just scrolled it down. We just studied upwards that metformin is used with another medication. So I hope you remember that this is often used as a second agent to metformin, right? These are gliptin ones. So the best next step is to add a gliptin, DPP4. Insulin is the last resort, so you don't go for that. This is L. Okay, this is not a tick. This is a tick. This is L. And so this is the last resort. Insulin pump again. This is not the next step. Prednisone is again not the next step. Acarbose not the next step, and you don't give sulfonylureas because they have a lot of side effects. So if a type 2 diabetes cannot be controlled with metformin, add a second medication. A DP4 inhibitor such as sitagliptin or an SGLT2 inhibitor is the most effective and safest option. If the patient had originally been given a sulfonylurea but was not adequately controlled, add metformin. There are several options before start having to start insulin. So this is a insulin is a last resort. So you give metformin plus DBP4, or you give metformin plus SGLT. And if you've not given them metformin before, you've given them any other drug such as sulfonylurea, you can add metformin to it. Rosiglitazone is contraindicated in CHF, and liraglutide adds weight loss. So do you guys remember which group had glutide in it? You don't remember? It was the GLP-1. So I don't think we've studied the GLP-1s. No, we've not studied GLP-1s yet, so it's okay. I think we're going to look at them in just a bit. So they help with weight loss, and rosiglitazone is contraindicated in CHF. DPP4 inhibitors, saxagliptin and linagliptin, alogliptin, and sitagliptin increase insulin release and block glucagon. It's an important point to remember. A basic science correlate the incretins is also called the GLP-1 agonists, glucose isotropic peptides, previously known as gastric inhibitory peptide. So not important, just remember this name. That's enough. Incretins increase insulin release and decrease glucagon secretion from the pancreas. DP4 metabolizes GLP and GIP. Inhibiting DP4 maintains high levels of GLP and GIP. GLP is a confusing misnomer. Glucagon raises glucose and FFA levels. GLP decreases glucagon. So remember that you're not supposed to get tricked by the name. GLP agonists decrease glucagon, right? So remember that they decrease glucagon. Okay. And I've already explained this to you guys. Incretins basically they increase the insulin release and decrease glucagon secretion. So this is exactly what we want in diabetes mellitus. Mechanism of diarrhea with glucosidase inhibitors when acarbose and mannitol block glucose absorption. The sugar remains in the bowel, available to the bacteria. When bacteria eat the glucose, they cast off gas and acid. Using glucosidase inhibitors is like making a person lactose intolerant. So they are explaining the rationale behind the most common side effect of using glucosidase inhibitors. This is the reason. Is that bacteria starts to act on all of that sugar that is remaining in the bowel. If lifestyle change and medical therapy do not sufficiently control the level of glucose, then switch the patient to insulin. Long-acting insulin glargine injected once per day, is given with a very short-acting insulin at mealtime. GLP agonists, exenatide, liraglutide, lexenatide, again, the butide ones, increase insulin and decrease glucagon. They promote weight loss. Again, this is a good thing. The glucose injected except semaglutide, which is oral. So you give long acting with a very short acting. And GLP agonists are described here. Long acting insulin, Ruragine once per day. The glutide extremely long life, less frequent hypoglycemic episode, determinate NPH 2 times a day. Short acting insulin, aspart, lisproglucin, given at mealtime. Last 2 hours versus regular insulin, which is also given at mealtime but lasts up to 6 hours. So this is the different. These are the different insulin ones that you must remember. If insulin does not sufficiently control the diabetes at metformin. And over here, they said that if lifestyle change and medical therapy do not control, add insulin. And if insulin does not control the diabetes, you add metformin. This is primarily for, I think, diabetes 1. GLP agonists slow gastric entering and promote weight loss. We know that exenatide. And semaglutide is the only oral GLP analog. It's good to remember it.